Hello everybody. I can see the recording has started, so I will just say hello and explain that we'll wait another couple of minutes as I know more participants are trickling in. Okay, it's 3 minutes past the hour, so I think I'm going to start and welcome everybody. In the interest of time, we'll just get started. This is the webinar on malaria control through schools. My name is Helen Mostu, and I'm a technical advisor for school health and nutrition for Save the Children US, and I'm moderating this webinar. As most of you know, this webinar forms part of the Fresh School Health and Nutrition webinar series, which provides monthly presentations by leading policymakers, researchers and implementers engaged in improving the health and education of children in low and middle income countries. To find out more and watch past webinars, and also this one in the near future, please visit the website, the webinar homepage at www.schoolsandhealth.org. And just to say that we will be disseminating this recording also. For the next 50 minutes, we'll have two 20-minute presentations conducted by three excellent speakers who we are very honored to have with us today. We have quite limited time for discussion, so I encourage participants to add their questions to the chat box. Hopefully you can all see that the space where you can add questions. And we can manage the questions there, and if necessary, we could also follow up offline after the webinar is finished. So the first presenter is Stefan Witek-McManus, a research assistant based at the London School of Hygiene and Tropical Medicine. Stefan has lots of experience in the implementation of large-scale cluster randomized controlled trials in low-income settings, and he was previously based in Malawi, where he coordinated the trial of the learner treatment kit. And this is a project being implemented by Save the Children and is still going on. And it is the results of this trial that he will be presenting today. Stefan is joining us from Kenya, where he is based, supporting a 2-year evaluation of the effectiveness of community-based deworming for the control and elimination of soil-transmitted helminths. We're also really excited to have the second presentation, which will be a joint presentation by Amina, Fakir and Christelle from SANOFI. It's a French global healthcare company. Amina is the Senior Manager of Strategic Partnerships within SANOFI's Access to Medicines department. She has over 20 years international experience in the pharmaceutical industry. She works closely with ministries of health and other partners to implement the malaria information, education and communication programs in endemic countries. And Christelle is the Information, Education and Communications Manager for the malaria program. Christelle is the person who develops the tools. So she is in charge of the mosque kit. She developed the mosque kit, which we'll hear all about, which is being implemented as part of Save the Children's SHN program in Mozambique. Christelle works closely with communities in sub-Saharan Africa, where she conducts pilot tests and training of trainers. Right. Without any further ado, I'm going to hand over to you, Stefan, who will start us off on the learner treatment kit study. Are you there, Stefan?
Great. Thank you for the introduction, Helen. And thank you everyone who's joining us today. So as Helen said, I'm Stefan, and I'm based at the London School of Hygiene and Tropical Medicine. And alongside the study team, I was the trial coordinator for this evaluation, where we were looking at school-based malaria case management, otherwise known as the Learner Treatment Kit, or the LTK, and its impact on children's school attendance in Zomba, which is a district in the south of Malawi. In the presentation, I'm just going to give a very brief overview of malaria in school-age children before discussing the design and the implementation of the learner treatment kit itself, and then share some of the process outcomes and the actual results of the trial. So just to set the scene for this webinar, I wanted to give kind of the contemporary picture of the evidence we have regarding malaria in school-age children. So I've summarised here most of the surveys we've had in the past 5 years reporting the prevalence of malaria in school-age children, and it's generally defined as the ages of 5 up to 14. So as you can see, kind of the prevalence can still vary quite widely, both between countries and even within. But with the exception of maybe 2 of these surveys, it's quite striking that school-age children harbour a very high level of parasitemia, and certainly levels that are much higher than we would expect to see, both in younger children under the age of 5, as well as older adolescents and adults. Less well understood, but definitely recognised, are also some of the differences that school children face in regards to key malaria interventions. So, for example, there's substantial evidence from around sub-Saharan Africa that school-aged children are far less likely to sleep under a bed net than other members of the household. And there's also evidence actually from Malawi that school children may face obstacles in accessing care for malaria. So, for example, compared to younger children, when school-aged children actually are febrile, they seem to be brought less often for treatment. And actually, when they are brought for treatment, it's more likely to be an informal provider, such as a shop or a kiosk, compared to, for example, their younger siblings. So in addition to simply the increased risk of developing symptomatic malaria and the clinical attacks, malaria parasitemia is well recognised to have a number of consequences, and notably that includes anemia. But school children are of course unique, that compared to other parts of the community, the majority of their time is spent at school, and so malaria is very likely to interfere with their educational development. And so this kind of simplified diagram highlights some of the key pathways. Now, the estimates of how malaria may contribute to absenteeism differ, but previously it's been put at around 8% of all absenteeism, but potentially as much as 50% of all preventable absenteeism. And more recent evidence from sub-Saharan Africa has quantified each episode of clinical malaria as responsible for between maybe 3 to 7 days of absenteeism. And so very briefly, there's a number of potential interventions that we can employ to address malaria specifically in this age group. And they'll include kind of preventive approaches with education or increased net coverage, intermittent preventive treatments, so seasonal malaria chemoprevention or intermittent parasite clearance, as well as sort of screening-based approaches, such as intermittent screening and treatment. Ultimately, a program of improved case management, so that's the green arrow and the red box, was identified as the intervention that was most appropriate for Malawi, and that was ultimately what was evaluated in this trial. So this has the potential to improve school children's access to prompt care in the event of a clinical attack, and also potentially address some of that preventable absenteeism that I mentioned earlier. The main component of this, though, would now kind of have to involve the use of RDTs, or rapid diagnostic tests for malaria, to provide a parasitological diagnosis, and the use of ACTs, or first-line antimalarial, for the actual treatment of malaria. And while the use of RDTs has been demonstrated quite widely over the last decade with more and more non-traditional healthcare providers, so community health workers or private sector shopkeepers, it hasn't previously been attempted with school teachers, and as such that was a big focus of the trial. And school-based malaria case management, though, is certainly not a new intervention, and we actually have a great example from Malawi, where a presumptive school-based malaria case management intervention was deployed at scale to around 100 schools between 2000 and 2008. And the intervention itself, kind of retrospective evaluation, demonstrated that it appeared to decrease absenteeism, but also actually reduced overall and malaria-specific mortality. And this intervention was only withdrawn in 2008 following those WHO recommendations that the treatment of a child over the age of 5 with malaria required a parasitological diagnosis and confirmation that it was malaria. There's also quite good evidence from other similar interventions in Tanzania and in Ghana that school-based malaria case management was acceptable and an effective way of addressing malaria. And just to frame the policy environment, I think in settings that are looking to achieve quite bold targets of universal access to RDTs and ACTs like Malawi, school-based approaches are certainly a very real and kind of feasible way to achieve this. And it's particularly true in a setting like Malawi where maybe 20% of the population are actually school age or enrolled at school. So a little bit about the learner treatment kit itself. So at each school, between 2 and 4 teachers were trained how to actually use the LTK, and they were called LTK dispensers. And initially this was a 7-day sort of training facilitated largely by Ministry of Health staff who were very familiar with training health workers in how to use RDTs. And there was also a very short refresher training at around halfway through the trial. So each school was actually linked to a local health facility, and that's where they would collect their supplies, which were held in a parallel supply chain specifically for the trial. Supervision was conducted by a task force comprised of officers from the district health office. And lastly, we developed a checklist for the actual execution of RDTs and the administration of antimalarials, and found that teachers were more than able to kind of demonstrate a level of competency similar to other health professionals and other users of RDTs. And I won't say much more about that, but it's available, it's published if people would like to read a little bit more. And a school first aid kit is actually currently defined in Malawi's kind of SHN policy, and it includes paracetamol, oral rehydration therapy, tetracycline eye ointment, and a number of supplies for sort of basic wound management. So the major addition for the learner treatment kit was the malaria-specific component. And as well as the actual rapid diagnostic tests and treatment, it also includes all the materials to actually use these. So that includes kind of the standard materials for biosafety, such as like sharps, containers, and gloves. The training and implementation materials for the LTK were developed through either adapting sort of pre-tested materials, so for example the WHO generic job aids that were developed some years ago on how to use an RDT, but also in some cases new job aids that we developed to support key tasks as part of the learner treatment kit. So for example a flowchart of when to use an RDT, a checklist of specific danger signs that each teacher should look for before providing any care, and a job aid outlining the different dosages for the different antimalarial treatments. And in all cases, these are in line with kind of broader national guidelines or standards relating to care. So the trial itself was a cluster randomized design in 58 primary schools, and it was primarily aimed at quantifying the impact of this intervention on school attendance. However, there were a number of secondary objectives, and the ones I'll discuss here were also to evaluate its impact on children's own reported well-being, a number of clinical and education outcomes, as well as the broader sort of community acceptability of teachers to provide malaria case management. So the trial itself lasted a year and a half, and following the training of those teachers in each of the 29 randomly selected schools, the intervention was implemented for 4 full school terms of about 10 weeks each. So they're the orange blocks here. And every consultation that took place was recorded in a treatment register at each school. School attendance, which is notoriously quite a challenging outcome to measure, was collected in 2 ways. One was by sort of strengthening the routine attendance records that teachers collected, in green there, and the second, in blue, was a series of unannounced visits to the school by study field workers, and what they would do was conduct a kind of a roll call of attendance in specific classes, and where a child was absent would probe for the specific reason, either from a sibling, a neighbour, or the teacher themselves, and where possible try to actually retrieve the reason for absenteeism. And lastly, to measure child-reported well-being, we pasted a series of charts in each classroom, and essentially if a child was present on a specific day, they had to draw a face on this chart next to their name to indicate whether they felt well, maybe not as well as they normally do, or whether they physically felt quite sick or unwell that day. And lastly, a cross-sectional survey here in purple took place at the end of the trial, and that's where we measured our clinical and education outcomes. So firstly, to what extent was the learner treatment kit actually used over the 4 terms? So the height of each bar here represents the total number of unique or individual consultations during each term, and it's matched roughly to the malaria transmission season at the bottom. So in total, we had a little over 32,000 individual consultations, and to give a sense of the scale, that's in a population of maybe 30 to 35,000 children at any one time. So by far the majority of the consultations took place in the 2 rainy seasons covered by the trial, with significantly less during the post-rainy and the dry seasons in between. Within consultations where an RDT was required, so that's following the standard Malawi and MOH guidelines, the proportion of RDTs that tested positive, so the green and the yellow here are all consultations where an RDT was conducted, and the green is where that RDT was positive. That remained consistent between the rainy and post-rainy seasons, and it only declined as we would expect in the dry season, when actually a significantly smaller proportion of all RDTs conducted were positive, at around 60%. One of the quite interesting process outcomes of the trial was that in every age group between the ages of 6 and 14, there was a greater number of total consultations provided to female students. And in this age group, there's actually relative gender parity in enrolment. It was only on the far right-hand side there where you can see that the number of consultations is kind of, the total number is equal between boys and girls, where actually the enrolment of boys is far higher than girls. We are looking at total numbers of consultations here, so that includes a child who might seek care a number of times, and it might be that we're seeing more of a pattern of repeated treatment rather than simply girls seeking care twice as often as boys. But it's still something we're kind of exploring and trying to better understand as we look at the treatment records in more detail. However, coming to our primary outcome, so we ultimately found no significant difference in absenteeism between the groups, either in terms of our teacher-reported register or our directly observed spot checks. So first with the teacher-recorded attendance in the middle, and this is reported as a proportion of all days that a child could be present, how many of them they were absent. And there is perhaps a small trend towards decreased absenteeism in intervention schools, but it wasn't significant. And likewise, our spot checks, we observed a small trend towards increased absenteeism in intervention schools, but again, this doesn't appear to have been significant. In terms of child well-being, again, while we did observe kind of an increased proportion of children in intervention schools in orange reporting themselves to feeling well or very well, and a greater proportion in control schools just reporting that they felt okay. Again, we found no significant difference when we compared across the groups here. Looking at our cross-sectional survey, so this was conducted at the end of the trial, we found no significant difference in the clinical outcomes of malaria parasitemia or anemia, or indeed our education outcomes. It's perhaps less surprising that we found no impact here, as these are kind of further along our causal pathway. However, specifically in regards to the education outcomes, we can say with some confidence that the intervention doesn't disrupt or negatively affect educational achievement. For example, because some teachers are spending time away from the classroom, carrying out consultations, conducting RDTs, and that was certainly a concern operationally during the rainy season when it really became quite a workload on some of the teachers. And lastly, and this is driven by some of the more recent research that I mentioned in Malawi looking at children's access to treatment, as part of the cross-sectional trial, the cross-sectional survey at the end of the trial, we also investigated a children's source of care the last time they were febrile. And encouragingly, you can see that in intervention schools, children were most likely to have sought care from the learner treatment kits, and significantly fewer seeking care from both a health centre but also from a shop compared to control schools. One thing I think that's interesting is that you'll see on the far right-hand side the proportion of children who said they did nothing remained the same in both controlled and intervention schools. So it suggests that despite having this intervention on site at the school, we failed to shift these individuals into seeking care when they require it. And lastly, in terms of our results, we also aim to evaluate the broader acceptability of the intervention to sort of policymakers, schools, and the school community. I've just summarised a very few points, but the references at the bottom there, and hopefully they should be available in the next month or so. So the first key benefit of the LTK really focused around how access to treatment had been increased or improved, and now the intervention was actually seen as a preferential choice for malaria care. Notably, caregivers actually kind of perceived a financial benefit essentially from being relieved of the burden and the costs that were associated with having sought care for their child in the past. Interestingly, the second major perceived benefit was this perception of reduced absenteeism, both around school absenteeism but also dropouts. And schools, in many cases, even frame the intervention as a sort of a benefit or a pull factor for attending school. In terms of a couple of key challenges, certainly one of the major challenges that kept coming back to was the significant workload that was created during rainy season. There were two kind of implications or suggestions to address this. The first was to train a greater number of teachers per school, that simply 2 to 4 wasn't sufficient to share the workload feasibly. And the second was around the kind of sustainability of teachers as volunteers. As teachers didn't receive any financial stipend beyond what they received for attending the LTK training, and while we had a few teachers transfer to different schools during the trial, we only had one teacher who declined to carry out the role during the trial. But perhaps this is a challenge looking at sort of the longer-term sustainability of the intervention. And lastly, the other major challenge was really around interaction with the health system, particularly around collecting new supplies, as well as getting feedback on children that an LTK had referred if they'd perceived them to having kind of danger signs or requiring further care. Over the course of the trial, and I think as the intervention matured, we did find quite simple solutions to these. So, for example, setting a specific time on a specific day that a health worker could go, was happy rather for teachers to come to their health centre and collect supplies. But I think it also highlights that for things to work most effectively, there's going to be sort of different solutions and tailored solutions in each of these scenarios. And then lastly, just to step back maybe and reflect on why we might not have seen an impact of the intervention, given the previous experience in Malawi, the very high usage of the intervention, as well as that evidence supporting our conceptual framework. The first is perhaps why, compared to the previous presumptive-based malaria case management intervention that had run in Malawi before, why we didn't see the same benefit. And just to say that looking a little broader within SHN, the greatest number of trials looking at school attendance tend to be around water, sanitation and hygiene interventions. And indeed, there is also sometimes quite inconsistent and mixed evidence around those type of interventions and which ones are most effective. Reflecting maybe on our study design, certainly a limitation of the trial is we weren't able to fully account for baseline attendance, as well as perhaps contextual factors that we weren't able to measure. But ultimately, I think we can be confident in the trial design, particularly the different ways we followed up attendance, as well as our success at following up children over 4 terms and actually across 2 different school years. And lastly, just to highlight again that absenteeism remains a very challenging outcome to measure. And during our spot checks, in the vast majority of cases, it wasn't possible to verify what the reason for absenteeism was. There wasn't anyone at the school who knew exactly why the child was absent. And while we could perhaps address that by doing home-based visits or kind of repeat visits to schools, that does inevitably require some quite substantial resources. And in the literature, it's only been done on a quite limited scale. So in summary, despite much higher than expected usage of the intervention, we found no significant impact on school attendance. However, the intervention was overwhelmingly perceived positively, and school children demonstrated a very high demand for care when it was provided at school. And lastly, we demonstrated that teachers can feasibly use RDTs and ACTs routinely to deliver malaria case management. And perhaps a priority in research into interventions.
The leader has disconnected. The conference will be terminated in 5 minutes.
Would be to sort of maybe look at compliance to treatment that a teacher provides and the broader sustainability over sort of several years. That's the end of my presentation. I'd just like to acknowledge the huge number of people that were involved in this trial, including the study team. And just to thank you all for listening, and I'm very happy to answer questions if we have a little bit of time.
Oh, thank you, Stefan. Thank you for sticking to the time limit. You did very well. I love hearing about the LTK. It's fascinating. I'm going to open it up to others. I have questions myself, but let's hear if there's anyone else who would like to ask any questions. We have 3 minutes, and then we have some extra time at the end as well. Anyone have any questions? Okay, well, I'll kick off. Stefan, I was wondering whether, obviously obviously there was no effect on the attendance, but it's clear that the LTK is great potential to increase access to treatment for the school age group, and it was so popular. I mean, I remember hearing that you had parents coming with other younger children coming into school and knocking on the teachers' doors, as all symbolic of the fact that there was such great demand for treatment. I was wondering whether we could go back to that slide with the bar chart just to get have clarity on the proportion of the school children who were accessing treatment throughout the year.
Yes.
I think it was one of the first results slides.
This one here, sorry.
Yeah, that one. It's not so easy to interpret, but because it's quite.
Sorry, yes.
No. Not. I've seen it many times. I love it. It's just that there's so many different ways of looking at the information.
Yeah. So this is kind of a summary of all of the consultations that we recorded during the trial periods, and we've just broken them up into the same those 10-week blocks, as I said about that we measured attendance, and we've roughly kind of attributed them to a malaria transmission season. So the total height of the bar is the total number of unique consultations, and just like where I showed it split into males and females, this is potentially individuals who have come for care more than once. And so in blue are consultations that the symptoms the child reported didn't require an RDT to be conducted. So the guidelines that teachers followed were the same as the kind of standard Malawian MOH, where it's a reported fever in the last 72 hours plus one of about 5 or 6 kind of defined symptoms. So in those cases, those were perhaps a child reporting an injury, a headache, diarrhea, kind of something that was not requiring testing of the malaria RDT. And then the orange and green are consultations where an RDT was required, with the orange being RDTs that had a negative result and green being RDTs that had a positive result. The proportion there in red is just showing out of all RDTs that were conducted, what proportion of them tested malaria positive. And while it remained really quite consistent between both the rainy and post-rainy seasons, as we might expect, it was a real decline into dry season when transmission decreases, and we see less kind of those excess infections, and we would expect to see a smaller proportion of those testing positive for malaria.
Thanks, Stefan. Just a quick clarification. You don't have the information on the proportion of school children that accessed the service?
We do. Unfortunately, I don't have a slide on it.
Okay, don't worry.
It is something we've actually looked at as a kind of exploratory analysis for the trial itself, and looking at whether children who actually access the intervention compared to those who we also surveyed as part of our, for example, our cross-sectional survey, but hadn't ever accessed the intervention, or, for example, had only accessed it once compared to several times. So it will be an interesting exploratory analysis, but it's not something, it's not something that we formally reported.
Okay. I've got a question here from Mohini. She's saying, if you were to do this again, what other outcome measures would you include in the study?
I think the things that we would be interested to look at would be perhaps focusing on some of the more operational aspects. So certainly looking at to what extent children complied with their anti-malarial treatment that was given to them by their teacher, because the intervention worked in a way that once a child tested positive at the school, they had their first dose kind of directly observed by the teacher, but then they took the remaining 5 doses along with a sort of illustrated instruction sheet for their parent back home, if they were an older child. If they were younger, we actually called an older sibling, for example, or actually a parent if the child was in standard 4 or lower. However, we don't actually have any information on to what extent children complied with that treatment, and also to how that compares to sort of routine clinical practice and compliance at a health centre. And that would certainly be very interesting to see actually whether treatments were being taken as expected and how that might impact on our outcomes of attendance. I think that would be something that we'd be very keen to explore further, but also these actual reasons for absenteeism, because with so much absenteeism being for unknown reasons, we're unable to quantify or how much absenteeism is actually attributed to sickness, to illness. Yeah. And compared to example for economic activities or financial reasons or whatever it may be, we don't have a very firm idea of actually how much absenteeism is due to sickness, and working backwards, kind of whether conceptually our intervention, how our intervention conceptually fits in with the different reasons for absenteeism.
Oh, thank you, Stefan. We could keep talking about this. I have so many more questions, but if you have any more questions, I see there's more coming in. We can. Oh, I think someone's not on mute, so I'm getting some echo here. But we can see if we can discuss at the very end if we still have time. So I'm going to have to hand over now in the interest of time to the next presenters, which will be a joint presentation by Amina and Christelle. And are you there? Are you able to take over as presenter of the screen? And click through to the end. I think you might have to click through to the next presentation.
Yeah.
Excellent. I'll hand it over to you, Amina. Thank you.
Yes, here we are. Okay. Hello, everyone. So thank you, Ellen, and thank you, Save the Children team, to giving us the opportunity to present today. And thank you, Ellen, for the brief introduction for both of us, Christelle and myself. So we are based in headquarters in Paris, and we are happy today to share with you some elements concerning our School Children Against Malaria initiative and the Mosquito Kit, the tool developed specially to support this project. So how it works? Okay, yes. So today we will cover briefly, I will be presenting what is SANOFI as a global health company, our social responsibility part, and go in detail to our School Children Against Malaria project. And I will give the floor to Christelle to go and to present the Mosquito Kit and what is coming next after the mosquito kit. Then I will be sharing what the partnership we set up with Save the Children in Mozambique, and finish with some key figures. So as you know, SANOFI is a global health company. We are committed to prevent diseases and treat patients across the world. We are more than 100,000 employees working to provide healthcare solutions in 170 countries. Our key therapeutic areas are mainly diabetes and cardiovascular, consumer healthcare, specialty care such as rare diseases, oncology, immunology, but we have also dedicated unit, SANOFI Pasteur, working on vaccines. So this one I will skip it, sorry, because I said it earlier. Our social responsibility. So unfortunately, one third of the world's population has no access to healthcare. And at SANOFI, we have a dedicated team working to promote access to treatment for those in need. We fight childhood cancer, we work on malaria, tuberculosis, but also on other neglected disease such as sleeping sickness, leishmaniasis, and Chagas. So now I'm pleased to present you our innovative School Children Against Malaria program. You all know that children are the primary victims of malaria, and thank you, Stefan, you present this very largely. But they are also the adults of tomorrow, and we are confident that they can play an important role in the fight against malaria. So our school-based program used the primary school children as a change agent to promote and lead individual behavior change. We started this program in Côte d'Ivoire in 2008, and we introduced malaria awareness in school with the National Malaria Control Program in that country. We, of course, set up all our programs, and this one especially in partnership. And today it really becomes a good example to demonstrate that schools can contribute and play a role to the community health and in the fight against malaria. So I will present briefly the main and common steps of the implementation of this project. So we first, of course, we need approval of all the stakeholders involved in the project: National Malaria Control Program, Ministry of Health, Ministry of Education, and the implementer partners. Then we start by training of the trainers on malaria, done by the NMCPs, and on the School Children Initiative and the mosquito kit by us, by SANOFI. We select 2 or 3 teachers by school and the directors to attend these training sessions to be trained. Then once trained, they go back to their schools and they set up a training session at classes using the mosquito kit. And after the classes, they set up an awareness session at the school through the games. After that, they use the school children to run a series of community awareness campaigns. And of course, the kids will play a role as a change agents and disseminate the right messages on malaria. So the project itself is designed like a school competition by using the drama, painting, songs, and of course we have a prize at the end, and the schools really play the role to make the competition successful. Now I will give the floor to Christelle to present you the mosquito kit.
Okay, Thank you, Amina. So I'm really happy to have the opportunity to present you the Mosquito Kit. It's an edutainment kit we have developed to raise malaria awareness among African children. Comment je fais? Je clique. Ah non, là. Ouais. Okay, sorry. Oh, it's small. So let's start. Various studies have actually emphasized the impact that malaria has on school absenteeism. It can be responsible for up to half of the school day missed, and also the potential power of school children in changing behavior. In 2007, the World Health Organization highlighted both points in a report which promotes the role that schools can play in the fight against malaria. So, keeping that in mind, SANOFI decided to create a training kit specifically designed for kids. Okay, this comprehensive toolkit was specifically designed for primary school in sub-Saharan African countries in order to provide teachers with an easy-to-use tool to conduct didactic and interactive learning sessions with school children on key messages for malaria prevention and control, and to help children cascade and spread the key messages within the community, as Amina already mentioned. The objective of the kit is to deliver the key messages regarding the prevention, the treatment of malaria in a fun way, so that kids can remember them and ultimately they can change their behaviors. So to develop the most effective edutainment toolkit, we worked with several partners, such as Ludimage, who is an international agency specialized in educational games for children, and local malaria and education experts, of course. Here is the kit. So as you can see on the slide, the Mosquito Kit contains 6 complementary tools. The first one is the user guide, which helps teachers to familiarize themselves with the various tools and rules of the games prior to organizing teaching sessions with the learners. The second one on the bottom of the left is the Mosquito Images. It's a fully illustrated educational flip chart which illustrates the do's and don'ts when it comes to malaria. This tool is particularly effective to foster exchanges between teachers and children. So after that, we have the Mosquito game, the board game on the middle, to be played under the supervision of the teacher so that they can reiterate some of the messages which might have been poorly understood. And to win the game, children must state the appropriate key message to address the problem they face. Another game is the Mosquito Cards. It is a card game to be played in a small groups autonomously, and to win the game, children must link the problem to the solution by forming a pair while avoiding the mosquito card. You can see on the slide, it's the red one here with the mosquito. And the last, the poster and waste chart serve as permanent reminders on the main messages in the class. Here is the Mosquito Kit. So before implementation, we conducted a number of field tests in real-life conditions in order to better meet the needs of children and teachers from local communities. This was done in collaboration with national malaria control programs, NGOs, as well as teachers and children from the 5 countries listed on the slide: Gabon, Niger, Nigeria, Ivory Coast, and Democratic Republic of the Congo. Approximately 170 children and 200 adults were involved, and the global satisfaction score was of 3.4 out of 4. So children enjoyed it and were very happy to learn in a different way from usual. Teachers were really interested and confident with this learning through play approach. And this preliminary work confirmed the quality of the Mosquito Kit and allowed us to make some adjustments and develop additional material before implementation. After the launch, we decided to demonstrate this impact in real life through scientific validated through scientific validated survey. So in collaboration, always with the NMCP teachers and DOs, we tested the kit in 4 countries: Benin, Burkina, Niger, and Togo. So we conduct them to assess the impact in knowledge, attitude, and practices among targeted audiences. And in total, almost 3,000 school children, 1,800 community members, and 200 teachers have been enrolled. These field tests post-launch confirmed us the skills acquisition or improvement, and that some false beliefs declined. For example, the more recent one was conducted in December in Niger with 2015 members. And we had very interesting, positive, and encouraging results, such as after the session, almost 90% of the children named mosquito as malaria vector. And in contrario, the misbeliefs that sun can be a vector decreased from 4.5% to 1.5%. So it was really interesting. And more significantly, treatment received from traditional healers decreased from 74.9% to 25.2%. So really, really interesting. So that's it for the mosquito kit. But after that, what next? The mosquito kit, the educational value and its effectiveness in the field have made it a reference tool for the fight against malaria among children. In March last year, the mosquito kit won the first prize in the category of the most valuable patient initiative or service at the High for Pharma Awards. And this year, a new comparative study focusing on the effect of games in the learning process will be conducted in Senegal. One group will be subject of learning sessions with only the flip chart versus another group which will have a learning session with the flip chart and reviewing the messages with mosquito games and mosquito cards. So we expect results maybe beginning of next year. And finally, building on the success of the mosquito kit, we are expanding our range of youth-oriented tool with an animated cartoon to cover all types of learning, visual, auditory, and kinesthetic. It is based on the graphic environment and characters of the mosquito kit, featuring Eddie, or Dabo for Francophone countries, a 12-year-old boy who fights malaria in a simple and educational scenario. The plot also presents basic messages on the management of the disease. And the film lasts approximately 11 minutes, alternating awareness messages and humor. By the beginning of this year, we ran a survey on a sample of 200 children in Kenya and the same in Ivory Coast, 2 ages level, 7 to 9 and 10 to 12 years old, and a mix of urban and rural, living in a household with less than $4 income per day. On all the questions asked, the average progression of correct answers is significant after viewing. Oh, sorry. Okay, you understand me. In Ivory Coast, it increased from 4.7 before viewing to 7.1 after. And in Kenya, it increased from 5.3 to 6.4. So now we have to enlarge the broadcast, and the communication plan is under discussion. But this tool will probably be broadcasted on TV5, Africa, and TV for young people on April the 25th. So for me, it's the end, and I thank you for your listening.
You have one more.
I have one more.
Amina and Christelle, I'm afraid we have just 2 more minutes to finalize. I'm sorry, we're running a bit low on time.
Okay. And it's okay. I will now hand you over to Amina for the last part.
Yes. I wanted just to share with you what we done with the Save the Children. I will be very quick, don't worry, Ellen. So with the Save the Children, I'm happy to see that Natalie is with us today. We discussed a lot and we decided at the end to choose Mozambique as a pilot to set up a partnership between both of us, SANOFI and Save the Children. So as you know, Mozambique is a very endemic country, and we choose Nampula as the district of setting up this pilot because it's a very high prevalence in the country. We tested the approach to integrate this initiative in the school health and nutrition program of Save the Children. And of course, it was multi-partnership program, involved the 70 schools where Save the Children run their SHN program. We launched the program last September with training of trainers session, and it has been it was greatly appreciated, and we are looking now with the team, Ellen, Nazanin, and others to extend it to Niger, Malawi, and maybe other countries. So just to finish, I want just to show you the scale up of this program. Today we are in more than 17 countries, and we reached over 8 million people with this program. And really, we strongly believe that these children can be the generation of end malaria for good. Thank you.
Thank you, Amina. Thank you, Christelle, for a fantastic presentation. Very impressive numbers there. And also happy to see that you squeezed in a couple of slides on the Mozambique partnership. We're very excited about that. We have a few questions. Mohini is asking whether when you, Christelle, this is a question for you about the pre-testing of the mosquito kits. I can, by the way, vouch for the mosquito kit being so high quality and so fun to play with. I just loved it. I wanted one for myself or my kids. But anyway, so we were wondering about the pre-test. Are there any specific criteria used for the satisfaction score that you mentioned during the pre-testing, or how do you measure basically the satisfaction?
That was focus group, and we asked children about their how pleasant they found how it was pleasant for them to play with the games, if it was easy to play the game, if they love, dislike the characters, the colors of the characters, how the draw itself, the environment with the message, everything that could be an issue at the end.
And I'm just curious to follow up on that. I think, do you see a lot of variation when you pre-test this tool in different countries? It's mainly sub-Saharan Africa, right, that you focused on, but between the different countries, do you see a lot of variation? And also by age? Which age group is it focused on?
Not really. This kit, we think that it's for primarily 7 to 12.
12, yeah.
It's the target.
Yeah.
And there were not so many differences between countries. In fact, we avoid any religious sign. We remove the caps. We covered the arms. We try to be as
neutral,
to cover a large. Neutral.
Yes, that's a word. That's true. So everybody was pleased.
Okay.
I will answer for the second question of Moini. So this it depends country to country, but in general they use the slot because the question was where at what time the teacher the children play these games. So the teachers choose the time of scientific or health slot time because every schools they have this health education slot time, so they use this time, and they use also the breaks to let kids play with games. For the curriculum, that's again depend on the countries, but for Côte d'Ivoire and some other countries, so in these 17 countries now, like 5 countries include really malaria and these kids in their strategic and in the curriculum of the teachers. But the others, I hope it will be done soon. But it's one of the objectives of the project.
Yeah. Thank you so much. And actually, I want to go back to a question that Jackie posed earlier to Stefan, which I think also applies to you both, Amina and Christelle. It's the issue around bringing in children who are school-age children who are not in school, and whether these children have access to the services that are at the school. So, I mean, I don't know, Amina and Christelle, does this apply? Have you seen, when you apply your program, this approach? Does it include addressing out-of-school children?
So we don't have any figures measuring that, but really the commitment of and the engagement of the schools and the community itself. As we design it as a competition, every people really are excited to be the winner, and they bring the kids to the school to this, because the project it runs within 6 months, and we have just qualitative feedback from the teachers and the directors that the kids are excited and they want to play, they want to learn, and they come and they come to school. But we don't have any evidence showing that the absenteeism is less than.
Yeah. No, I can imagine it's a big attraction. Stefan, do you want to say a few words about that for the LTK? Are you there, Stefan? If the question is whether it helped attract out-of-school children to come to school, I don't think this was actually included in the trial, but maybe you could say some words. Okay, Stefan is not there. Never mind. I'm going to spend the last minute to announce that we have our next webinar. It's going to be on menstrual hygiene management next month. I presume it'll be the 15th, but that will be confirmed, and we'll send out an email to you all. And we will be uploading this recording on the Schools and Health website and disseminating it. And thank you again to all the speakers. Brilliant presentations, and if you have any further questions, just get in touch and we'll forward it to the speakers who can get in touch. It's 15th of May. Mohini has just confirmed our next webinar. Thank you so much, everyone.
Thank you everyone.
Bye-bye.
Bye.
The leader has disconnected. The conference will be terminated in 5 minutes.